Oh my goodness, everybody's awake and into it. This is awesome. Man, I wish my residents were like this. Cool. Okay, so we've been focusing on all these really interesting ways to diagnose high-level, high-end athletic injuries. Now, my talk is about joint replacements, so we're going to slow things down a little bit, back things up a little bit, and then we'll ramp up more as time goes on, right? I'll first start with disclosures. I work with 4 different implant companies with implant design. Although I'm not going to discuss individual company issues, I am going to discuss some implant design-related features, so I thought it was important to include these. So first, the question then becomes, why consider the study of physical activity with hip and knee replacement? Why even bother, right? Well, this really interesting study by Michael Reese out of San Francisco a long time ago looked at 30 patients that were going to undergo hip replacements, and then 18 age, gender, and osteoarthritis level matched patients, and assessed their cardiopulmonary function and their arthritis impact measurement scale, assessing them preoperatively at 6 months and 1 year and 2 years, right? Between those two cohorts, in the total hip group, their exercise duration markedly improved, their maximum workload markedly improved, their peak O2 consumption markedly improved, the percentage of predicted maximum oxygen uptake include, and their AIM scores obviously include. Whereas in the control group, the people that had arthritis and that chose not to have surgery had marked declines in their exercise duration, maximum workload, and workload at the anaerobic threshold. This is not new, but this is data as opposed to what we were talking about before. So there's clear data that hip and knee replacement significantly and positively affect health. Movement, as we all know, is the only real fountain of youth, right? So the question then becomes, what sports participation is appropriate for this cohort of patients? You might ask, well, why ask that question? What are the potential problems with sports and joints? In this nice biomechanical study by Basset, they measured in vivo hip joint forces at the implant in slow jumping and counter movement style with fast continuous jumping and jogging in place. And what they measured were the implant forces, the force the implant itself was seeing, were between 250 and 400 times body weight. That's approximately twice the magnitude of the ground reaction forces. And they were significantly correlated with muscle activity. This is brought home by this study by Bergman that assessed fast walking and jogging at 550% body weight, and stumbling and catching yourself, that's 870% of body weight, because the magnitude of the hip forces increased considerably, not only by the external load, but by the muscle contraction that are trying to fight that load. And for this reason, higher impact activities could affect the durability of that implant. Now, this is an implant in a bone in an MTS machine, and it's here to demonstrate that both the implant and the bone are progressively bending with each cyclic load, and they bend individually and they bend at their union, right? So that interface between the bones and the implant is seeing significant loads. Now, we can only talk about joint replacement in this realm because of very significant technological advances in implant strength, in metallurgy, so that this kind of crack, which has happened, no longer happens. Second, in how the implants are attached to bone, whether with bone ingrowth, you can see how the bone has become introduced deeply into that implant. That implant is a structural part of that body, or with cement, as the cement pieces are interlaced into the small interlaces of bone, just like cheese melted onto an English muffin. It's that broad surface area that allows the load to be transferred. But among all the things, it's the diminution in surface wear that is most interesting in allowing us to be able to have patients pursue these activities without guilt, without our guilt. So this is a retrieved acetabular component in a patient who was 52 and had it in for 3 years before he had a horrible infection. He was very active. And you can see that you can still see the machining lines on that socket. There was almost no wear that occurred in this very active patient. So this is what allows us to think about these concepts. This is in a total knee replacement model. This is successive versions of implants with technological advances in either the polyethylene or the metal surface. And you can see in the 2000s, the wear on a wear machine was at a certain level. With each successive increase in the technology that's applied to these implants, there's a magnitude, an order of magnitude level drop in the wear rate. So wear has been markedly affected by these technological improvements. So then, given that, okay, so patients can potentially return to sports, but which are the predictors of those patients that can and cannot? In this really nice study out of Marseille, they looked at 571 hip replacement patients. It was a relatively young group. 61 is becoming younger every year. Mostly men. These were not big guys. The largest BMI was 31, and this follow-up was 9.8 years. And they assessed the levels of sporting activity and the predictive factors for return and tried to correlate participation with satisfaction. In this cohort, 64% returned to their level of sport as defined by UCLA score greater than 6. Among the reasons for not returning to sport, and these reasons have recurred throughout the day: fear, avoiding wear, physician recommendations, stiffness, and pain at the hip. The take home from this study was the higher the Harris hip score, that is, the better they were clinically, the better they did, the more likely they were to return to sport. The shorter their durations of symptoms, right, less than 1 year, were more correlated return to sport. And finally, and most importantly, as we all know, motivation to participate. Those patients who considered returning to sport activity as very important in their questionnaire were significantly increased in their chance to be able to do so postoperatively. In this study, there were no correlations between activity level, age, gender, or BMI. But there was a correlation with patient satisfaction, a negative correlation with younger age, with post-op UCLA score, and with pre-op Harris hip score. That is, the healthiest and most active pre-op patients had the highest post-op expectations and therefore were somewhat less satisfied with what they achieved afterwards. Now let's think of patients' perception in their return to play and what was practiced. In this study by Clifford and Mallon, they interviewed all of the surgeons that were members of the American Association of Hip and Knee Surgeons to assess what were the sports that they considered high or low impact and which one they would suggest that patients can go back to. And as one would think, jogging, contact sports, these were considered high impact, and in general, they were not allowed by the surgeons. Tennis was considered intermediate, including downhill skiing. For some reason, they considered speed walking as potentially low. That makes no sense, and it tells you that the people that are making these decisions are not making these decisions with data. But this is what the surgeons at that time considered appropriate for joint replacement. In this study out of Bristol, England, they surveyed 2,000 patients that were part of the National Health System, all of which had one type of a joint replacement or another, and asked what was their participation in sports in the 3 years before joint replacement and were they able to return postoperatively. In this series, 34% suggested that they had been active in sports preoperatively, although that preoperative participation declined with age, no surprise on that, and was more common in women. These were the sports that they were participating in. Again, these were English, so they played Skittles. This is Skittles here on the bottom, by the way. It's kind of an odd bowling bocce thing. 61% of them were able to return to what they wanted to do preoperatively by 1 to 3 years post-op. Again, the reasons they didn't were pain, inability to achieve the movements, medical advice, fear of damaging the joint, and that ever-present lack of confidence, which is not just mental. That lack of confidence comes from something. The largest decline were in the high-impact sports, tennis, dancing, and badminton. Now, this study out of London, rather than Bristol, this is a compilation of 42 different papers regarding athletic activity and lower limb arthroplasty. Among the 40 papers, the rate of return to sport varied from 54% to 98%. There were higher rates of return in younger age, male gender, lower BMI in this study, participation in sport preoperatively, and the absence of other joint pain. That's only going to be present if you ask the question, of course. In assessing the survival of these implants, in none of these studies was sporting correlated with poor survival. There were no increased revisions in the sporting population. There were no increased revisions in those patients that had a greater UCLA or Tegner activity scores. 3 studies noted an increase in polyethylene wear in this group that were all 5 to 10 years follow-up, and so they were all pre-cross-linked polyethylene. Their conclusions were that joint replacement patients were able to return to sporting activity, that intensity of activity tends to be less than before the surgery, and at midterm follow-up there was no increase in joint implant failures in these active patients. There were some studies that did show radiologic wear in the active population, but no increased revision rate, and again that's related to the quality of the polyethylene they had at the time. This is a really interesting study that compared total knee replacement to partial knee replacement, and you can see their mean follow-up was about the same. The return to sport rate on a total knee was 63%, on a uni was 96%. Average return time was similar. 80% felt that their surgery increased or maintained their ability in the total knee group, whereas 88% felt so in the uni group. There was a highly significant reduction in golf, bowling, and a significant reduction in swimming and dancing in the total knee group, with very little change in patients' low-impact sports postoperatively in the uni group. Now, most importantly, 42% had pain during their sport with a knee, only 24% with a uni, and 27% of the total knee patients felt that their knee was unstable while they participated in sport. And that's really interesting because with a uni, you're saving all 4 of their ligaments, right? Whereas with a total, you're sacrificing at least 1, if not 2, and then part of what you have to do is reproducibly reproduce the position of the condylar surfaces with respect to those joints. And it's that variability that we're not able to do reproducibly with a total knee that you don't have to worry about with a partial knee replacement. Now, if we look at an older population, these are sporting people between 60 and 80. So their mean age at surgery was 71, mean follow-up was 6, so they were now about 75, 76 at the time of their follow-up. And still, their mean sport time was 5 hours a week. At 6 years, 25% remained active in high-impact sports as defined by, this is a German study, so alpine skiing, rock climbing, dancing, and tennis. And 47% were active in medium and low-impact sports. In this study, there was no difference in polyethylene wear, and the WOMAC and the KOOS quality of life were significantly correlated with sports activity. No surprise there. So let's think about more about long-term follow-up. This is another German study looking at 86 patients having undergone hip replacements. Again, their mean age was 53, so it's a relatively young cohort. In fact, 53 is a really young cohort. It's my age. They looked at their UCLA Shield test scores of activity and the quality of life measures. At 11 years post-op, in the preoperatively active population, 89% were still performing their sport. In this German study, there was no significant perceived questionnaire-given data difference in pre-op to post-op. Again, that's their perception. Whether that perception represents reality or not is a separate issue. In the intense activity group, as defined by UCLA score greater than 7, 41% of those people, 41% of the cohort were in that level. There was no significant increased wear or radiolucencies or osteolysis. Now, in this group, over the course of 10 years, there was a slight decline in the high-impact activities such as soccer and tennis, and an increase in low-impact activities such as swimming, cycling, and gymnastics. The reasons that were described were to preserve the prosthesis in 61% and age-related reduced physical fitness in 22%. There were some cups that had increased wear of the plastic. All of those had an acetabular component that was placed at greater than 50 degrees of abduction. So there were technical issues in how the implant was done that may have contributed to that as well. And so in this study, a higher percentage of patients are not only able to return to sport in the short term after total hips, but were able to maintain that activity in the long term. In this study, on the knee side, slightly different, 236 knees, mean age at surgery 62, minimum 10-year follow-up, more like 14 mean follow-up. Looking at Tegner, WOMAC, and VAS scores, they were still, even at a mean 15 years follow-up, improved Tegner scores compared to pre-op, and markedly improved VAS scores. that in that same study, 71% were playing low-impact sports, 43% intermediate impact sports, and 16% high-impact sports, including jogging, handball, volleyball, and basketball. The correlation of the pre-op Tegner and Womack scores with the post-op scores once again suggests that the level of the pre-op functional sports activity influences the post-operative outcome. What you come with determines where you go. So what have been some consensus recommendations from implant surgeons in the past? In this study from about just under 10 years ago, saw a consensus among surgeons, and that consensus was an agreement that swimming, golf, and cycling, quote unquote, low impact, were permissible, but that contact sports and jogging, high impact, were not. 6 months post-surgery was considered the most acceptable time for a full level return to sport. And again, these are based on individual experience of the individual surgeons combining to make this consensus. More recently, a Danish group of surgeons have completely turned around. They allow most athletic activities after hip replacements, even 55% for high impact activities in hips and 38% in knees. So here you can see that the surgeons are perceiving a difference in the quality of the arthroplasty from a hip to a knee and are less likely to recommend a more high level activity. So let's look at now some individual sports. This is another French study. They sent out questionnaires to members of the French Judo Federation. In order to be in inclusion, you had to be a licensed judoka, greater than 60 years old, have at least a black belt 6th level, and have a joint replacement. And they got 38 patients in this level. Of those, the surgeons had told 25 of the 36, or 65%, to switch to low-impact sports. And still, 29 of them, 76%, returned to their judo, although none competitively. They changed the way they practice, but still 2 to 3 times a week. And one of the quotes from the study was, "It's difficult for a judoka to give up practicing the sport because judo is also a life philosophy." They returned at a mean of 4 months after surgeries. In this group, there were 2 revisions for loosening and 1 revision for instability, but interestingly, no dislocations or fractures in this judo population, and 84% were satisfied with their situation. So now let's step it up a bit to running, right? Running is a big deal. Should we even consider this? So this is a series of 40 patients that underwent hip arthroplasty, hip resurfacing, because this was done in the late 2010s, and anybody who was having an arthroplasty less than 60 years old was offered a hip resurfacing. In this mean group, a mean age of 50 pre-op, all had stopped running due to pain. At their last follow-up, 33 of the 40 had returned to running and were still running with a mean return time at about 16 weeks, obviously at a light level. Their mean time spent running at follow-up was 3 hours per week. The mileage decrease was noted only in patients over 50 years of age. I'm not sure what that's about. But patients were still running, and some competitively, and there were no revisions in this series. Now I'm going to introduce you to Frank. Frank is like an inspiration to me. The guy is awesome, and probably 3 individuals in this theater have either operated on him or treated him post-operatively. So I operated on him. I did a hip replacement in 2001. He said, "Doc, can I run?" I said, "No, you can't run." He said, "Okay, fine." Of course, he went ahead and ran. And here we are, 5 years post-op. 6 years before, this is in 2007, when I had just come back from Iraq, and he found me underneath the Verrazano Bridge because he had heard that I was going to run the marathon. He said, "Run with me." I said, "I can't run with you because then I'd be condoning you running." He said, "Doc, I'm going to run with me." And he ran with me up until mile 20, and he said, "See ya." And as I was hitting the wall, he was out of there. So Frank is special because he just doesn't let anything stop him. And on that particular one, he got 3:47. I didn't make sub 4, unfortunately. I was notably after 4. I was 4:12. Really annoying, but whatever. Again, patients who considered returning to sport activity very important had an increased chance of doing so post-op. But not only that, you got to keep on, right? This same gentleman had an Achilles tear, which was repaired downtown, not well. Came here, one of our guys fixed it properly, and he returned to running. Then he had a problem with his back, and I had to introduce him to one of my friends upstairs who fixed that. This is his knee in 2003 when I had seen him for 2 years after his operation. Here's in 2007. Here's in 2013, he was starting to have mechanical symptoms. He said, "Doc, you got to help me out." So we did a knee arthroscopy and mastectomy chondroplasty. He had a fair amount of arthritis already. And then another member of this illustrious hall operated on his shoulder, made him feel better there. Now here's his hip replacement when I first did it in 2001, and then 15 years and 5 marathons later in 2016. And you can see there's nowhere evident. The bond of the implant to the bone is pristine. This is a situation where it worked, and it worked amazingly well. Now, just earlier this year, his knees finally came out, and he had to have bilateral knee replacements. And here he is. There's no.
For yourself. You have 2 legs. You're off the couch. Get out there and do it.
I love Jackrabbit because they tailor to my needs as a runner.
The staff is phenomenal. They're very knowledgeable about the products.
It's the place to go, whether you're a weekend warrior or you're a world-class athlete.
I love Jackrabbit.
I have no financial association. What happened?
Is that his knees?
Yeah. I have no financial association with Jackrabbit. But I love Frank, and Frank is a special guy, and he is my inspiration. Now, returning to play after, specifically with golf, the quote-unquote low-impact concept. With hip replacements, this study out of 2007 looked at 66 golfers that had unilateral hip replacements. 13% were unable to return. Only one of them cited the hip as the problem, and the other 6, there were back problems and other joints that were the issue, right? All these joints age at the same rate. 57, however, returned at a mean of 5 months post-op. 54 saw an improvement in the game. 22% had a greater driving distance. However, handicaps at 3 to 5 years later increased by an average of 5 strokes. And the patients still had markedly improved pain, Harris hip scores compared to pre-op. In a study by Mullen and Callahan, also on hips, 115 golfers, at 6 years their handicap had increased by 1 and their drive length had increased by 3. Of note, there are 10 pros that have returned to competition after hip replacement. Knee replacement, still in this study by Jackson, 94% returned to playing their desired sport at a mean of 8 years post-op, right? So this is something you can keep on doing. The same study, Mullen and Callahan from before, 83 golfers, 5-year follow-up. Their handicap at 5 years from their surgery had increased by 2 strokes. Their drive length had diminished. Of note, patients that had knee replacement on their leading leg, 21% had mild ache during the playing and 42% had mild ache after, whereas on the lag leg, 88.3% during and 25% after. Interesting, in this study by Hamai, they looked at the swing and the effective swing on kinematics and noticed that the peak loads were notably on the lead leg after transfer of weight. Only 2 pros have returned to competition after total knee replacement. In this study looking at return to golf after joint replacement, a recommended progression to golf was suggested based on whether it's hip, knee, or shoulder. Now, I showed this phased concept of return to play to Dr. Nicholas when I first saw it, and his response to me was, whoever wrote that up has no idea what it's like to be a competitive golfer. And I kind of understand. This is a really interesting study, and I'm coming to an end now. This is a study of the kinematics involved in a golf drive, because there's a fair amount of rotation that can occur. And so they did serial x-rays during a simulated golf drive and subjected those x-rays to 2- and 3-dimensional model imaging techniques and model constructs from the CT superimposed on the 2-dimensional radiographs. And one of the things that they were looking at were what were the risks to dislocation. For example, at here, you can see the neck is impinging on the socket and there's some translation that's occurring. So there's a certain amount of distance that ball can move with that impingement right? A certain amount of translation, and that is dependent on the position of the socket. So they measured these two impingement and translations and looked at the two groups, the group where there was liner to neck contact and the group where there wasn't. So 36% of the patients had liner to neck contact with external rotation during the swing. In none of those cases was implant malposition responsible for it. In patients with larger maximum external rotation of the leg, there was a greater likelihood of that to happen, and there was greater translation of the femoral head slightly out of its depth of position socket. The more anteverted, the more forward-leaning the cup was, the more likely this was to happen. The less stem anteversion, also, the more likely this was to happen. And the use of elevated liners also predisposed to impingement. However, in none of these cases was true dislocation ever a risk. And I'm going to end with some alpine skiing data, which is really interesting because it was such a rigorous study. They looked at 14 patients that had a knee replacement, and they were subjected to alpine skiing as a means of therapy, right? As opposed to a control group that just could do anything they want in the gym, but weren't skiing. And these were all led by an intermediate level. They were all intermediate level skiers before, and they were led by guides to make sure that there was no injuries that occurred. In all the studies, regardless of which, the clinical function was excellent and the radiographic function was excellent. So that there was no difference between the groups. Now they looked at leg muscle strength and cardiorespiratory fitness, and they noticed, comparing the operated leg to the non-operated leg, there was a marked increase in muscle strength when measuring by single joint isometric extension, as well as by multi-joint isokinetic strength testing, with no change in the control group. That is, the patients that did not do alpine skiing did not have these changes occur. So directed alpine skiing is a pretty awesome type of therapy. There was also marked decrease of asymmetry between the operated and non-operated legs over time. In the study, they took a small number and did actual muscle biopsies and noticed increased muscle mass and no signs of significant sarcopenia in those muscles that were biopsied. There was a more symmetric gait. There was a faster descent time in the ski group compared to the non-ski group. The measured ground reaction forces via pressure insoles, the symmetric loading, there was more symmetric loading while skiing between the non-op and op leg. And increased ground reaction forces were not at all increased or associated with increased pain in general. Finally, they did a metabolic aspect of the study, and they noted improved glucose homeostasis, decreased fasting insulin, increased HOMA-2 insulin resistance index, and an increase in the muscle glycogen with no significant changes in the inflammatory markers. So this skiing group showed markedly increased physical activity compared to the control group and enhanced well-being with no significant perceived impact on pain, exertion, or knee function. So my recommendations, when people say, can I do this sport? I say, look, if you're a sportsman, you understand that sports participation has risks, right? Falls, fractures, wear and tear, it happens to our bodies, it happens to our implants. Patients will sometimes come to me and say, I'm a marathon runner. I say, when did you last run a marathon? They say, 2011. And I say, you and I were marathon runners. Our bodies have changed since then. So where is your body now? When was the last time you ran? Whatever activity you want to do, when was the last time you did it? The further away that is, the less likely you are to do it. Again, and not only because of the hip or the knee, the entire body, as has been reviewed by Jim Nicholas' concept from the beginning, the entire body changes with activity level. If you want to return to the sport, have your operation, allow healing first, and then train intelligently, understanding that training is injury and repair. You need both in balance. Push gently and listen to your body. So, if you're into competitive dancing and you want to be number one, you can do it. If you want to hit people hard in the face with your foot, you can, right? You can do high-level kung fu. You can be a grandmaster stick fighter. You can run triathlons, or you can be one of the most prominent yogis in New York after joint replacement. if you train right, and if you don't wait until you're too bad to do it again. Thank you very much.
Thanks, Jose. It was a great talk, and this is going to become more and more important as the baby boomers age. And you know, the baby boomers are the ones who went through the fitness craze and the jogging craze and all that, and their desire to at least maintain some activity is going to exist. And there are few joint surgeons that really allow it. The data I think that you showed doesn't really show. You have some wear that you see with the old polyethylene, but you don't see any detriments to exercise. And I think this education has to get out there so people are allowed to exercise more, because I'm used to people being told you can walk, you can play golf, you can play doubles tennis, and that's it. So I think it's great to have this information. Any questions for Dr. Rodriguez? Michael.
Dr. Rodriguez, great talk. Thank you very much. So you show in golfers that if they, as they rotate, you get some impingement on the leg. So given that, if you haven't had a golfer, have any recommendations for therapists that are working on range of motion, should we be pushing for full range of motion, or should we back off a little bit and try to minimize that impingement?
So I don't think that you should change what you do based on this study, because the anterior capsule with a large head is going to stop it from moving at a certain point. And that's one of the things that was noted in the study. There was movement, there was impingement, but there was movement, but it was always captured and it was never an issue at risk. So I don't think that you should modify a system that you've developed to bring patients rapidly to the point where they want to be.
I mean,
Jose, great talk as usual. Regarding total knees, as per Steve, if we want to try to get our patients to be able to do more sports and no longer tell them what I learned, which is walking's fine, golfing's fine, doubles tennis is fine, how have you changed what you say to your patients about what they're allowed to do and when?
So, of all the things that have changed in how we do knee replacement, probably the greatest has been paying attention to the kinematics of the knee. The idea that the medial and lateral side should be balanced does not necessarily mean that they should be equal, right? Your stability comes from the medial side, your mobility comes from the lateral side, and that means that the medial side has to be snug, but not super tight. And the lateral side has to have some laxity to it. Anyone that has operated on knees understands that the physical characteristics of the medial side and the lateral side are different, right? The medial side you open and it stops, the lateral side you open and you can keep stretching it. So I focus from a technical perspective on getting that soft tissue environment as optimal as it can be. Once that's optimal, I really have them not go crazy for 3 months. I tell them I need 3 months for this implant to get strong before you stress it. We're training them. I have them on an exercise bicycle within 2 weeks. We're doing squats, but in certain competitiveness, a full 3 months and then a gradual progression. And it's something that I say, tell me what you want to do, and then I, in conjunction with the therapists that are in this room, say, okay, how are we going to get them there? And I interact with the therapists with great frequency.
any other questions? Yeah.
I read in an article that the shelf life of implants affects the outcome of the replacements, joint replacements. So why is that? And if does a patient have a choice in that, like choosing the implants?
Okay, so progress in life is always 3 steps forward, 1 step back, right? We have had some amazing progressions in cross-linked polyethylene. Along the way, we have made judgment errors with other surfaces that have seemed to have promise, but wound up being significantly worse than the other ones. The patient always has a choice because they choose the surgeon. In most cases, however, the surgeons will have a thought process, and a patient can always influence that thought process. Just like if a therapist does a maneuver and the patient says, wow, that didn't work. That interaction is what makes the quality of the relationship and what the final result. However, I have some pretty strong opinions through seeing failures over the years as to what works optimally. So if you come to me and ask for something, I'm more likely to convince you of why I do what I do.
Any other questions?
Well, regarding the shelf life, I find that the patients coming in younger and younger with the total hip replacement that are very active, competitive athletes, not professional but competitive, that they're afraid to go back to that competitive atmosphere because they're afraid long-term of having a second surgery or a second replacement. Not that they have a problem with now, it's just the fear of the future.
So I have some good friends of mine that are my colleagues who were once really, really good active mountain bikers. And then they became surgeons and they have families and they're scared of injuring their hands, so they don't mountain bike anymore, right? The truth is, you could get hit by a cab crossing Lexington Avenue. So might running a marathon cause excessive wear? Absolutely. On your hip replacement and on your non-replaced hip. And that's why I started out the way I did. What we do has risks. And if what you want to do gives you that great pleasure, then do it. Understanding there are risks. And if you could run for 20 years and then have to have it replaced, what are you willing to do to achieve that, right? So there is no yes and no, it's all gray. And I try to pick out the white and black pixels in the gray and let the patient make their decision.
The other issue really becomes, there's some evidence that the benefits of the exercise might outweigh the detriments of the exercise, even in the joint. I mean, certainly marathons is extreme, but running in general, 2 to 5 miles a day might actually give you some chondroprotective effects rather than chondrodestructive effects. So we can't just say that running's bad for you. And the other thing is, the marriage between a sports-minded and a joint-minded person needs to be intermingled, because joint replacement surgeons classically try and preserve the joint, sometimes at the risk of the heart and the lung and all the other systemic issues that might arise from someone who's not conditioning. So it's important to understand that we fix the joint to improve life, and if you're taking away life to preserve the joint, you're really not doing the job. So, any other questions? Okay, Jose, great job. Thank you very much. Thank you.